Coming up on Mayo Clinic Q&A.
Probably around 5 or 7 million people that are suffering with a-fib. That's
Oh,
estimated. But the more worrisome thing is it might be much more common than that. And why? Because people don't walk around saying, hey, I'm in atrial fibrillation, come treat me. They don't know.
Atrial fibrillation, or a-fib, is an irregular and often rapid heart rate that can increase your risk of stroke, heart failure, and other heart-related conditions. While a-fib usually isn't life-threatening itself, it is a serious medical condition that sometimes requires emergency treatment.
So there's a whole bunch of comorbidities that could cause this. Mainly things that are really in parallel with developing atrial fibrillation is when someone has long-standing high blood pressure or hypertension. Also, if someone has sleep apnea, that's another trigger towards this. Or if their thyroid hormones are off balance, those are all triggers.
welcome everyone to Mayo Clinic Q&A. I'm Dr. Helena Gazelka. Atrial fibrillation, or a-fib as it is sometimes known, is an irregular and often rapid heartbeat that can increase your risk of strokes, heart failure, and other cardiac problems. Episodes of atrial fibrillation can be self-limited or they can go on for a period of time and need treatment. Although atrial fibrillation itself isn't usually life-threatening, it is a serious medical condition, and it sometimes requires emergency treatment. Here with us to discuss this today is Mayo Clinic cardiologist, Dr. Christopher DeSimone. Dr. DeSimone subspecializes in cardiac electrophysiology. It's a field that focuses on abnormal heart rhythms, essentially. Thanks for being here with us today, Chris.
Thank you, Dr. Gazelka, and it's a pleasure to be here. And I have a really strong passion in cardiac electrophysiology, especially in atrial fibrillation. So whatever we could discuss today to make our patients more at ease, make them feel comfortable, I'm all for. So I'm
Well,
looking
I
forward
think
to this
that's the
talk.
first point to make, Chris. I am sure we have listeners out there who had no idea about cardiac electrophysiology, much less that someone would specialize in it.
That's
But,
right.
but today we're talking about atrial fibrillation. So what happens to the heart
Right.
when someone has atrial fibrillation?
It's right. So the way I like to explain it to patients is the heart is like a two-story building. You have the top as well as the bottom floor, the basement. And the basement's where the money is, the real contraction and the strength of the heart pumping blood to the rest of the body. The top is kind of like where everybody kind of hangs out, and those are the filling chambers. But for those to coordinate and beat in a fashion that's manageable for life and to not give people symptoms, these are all dictated by various cells in the heart, which could coordinate electrical conduction with mechanical contraction of the heart. So in atrial fibrillation, the top of the heart is kind of going irregular. And what I explain to my patients is this is like a bag of worms. It's kind of like trying to squeeze, but not squeezing efficiently. And when it's doing that, two things are happening. One, the heart's not filling adequately and pumping blood out to the rest of the body. And you can imagine people could get symptoms such as headaches, lightheadedness, dizziness. Some people get chest pain. And overall, a lot of people just feel crummy and malaise. And also, the pressures in the left side of the heart back up and they start to get higher. And that's where people could get really short of breath because that chamber is what's taking blood that's oxygenated from the lungs. And the pressure sort of builds up in the lungs and gives people a really uncomfortable feeling.
I love your analogies. Two-story houses and bags of worms. I can picture it all. I'm picturing the little people in the two-story house. Chris, how common is atrial fibrillation?
It's very common. So the thing I would say there's sort of probably around 5 or 7 million people that are suffering with a-fib. That's
Oh,
estimated. But the more worrisome thing is it might be much more common than that. And
mm,
why? Because people don't walk around saying, hey, I'm in atrial fibrillation, come treat me. They don't know. And maybe they're accustomed, or maybe they say, oh, I'm just getting older. This is just the way life is going to be. And they're not used to it until it's picked up in the office with their primary care provider at a PAMI visit for preoperative for surgery. That's classic. So you hear the patient got, this was found right before the patient was getting a colonoscopy. So it's incidentally found, and then patients say, that's what's been going on. I could tell this has been going on for a
uh-huh.
couple of years. And the second thing that's very concerning is that there's an estimation that this could double or even triple in the next decade or so. So it's going to be common and more common as the population ages and
Oh,
we have a
yeah.
growing population.
Chris, the one thing I thought of when you're describing the symptoms is that I could imagine that people, as they're growing older, may write off the fact that they just feel kind of lousy or they are a little fatigued or maybe a little more short of breath because maybe we just think, well, I guess I'm getting a little older. I can excuse that.
Exactly. And what happens is, it's a good feeling for me, but I imagine it's a bad feeling for them because once I'm able to get them back into normal rhythm, they say, oh my goodness, I wish I would have had this taken care of. I didn't realize how bad it was. So I think to make people feel better sooner and quicker and to make them aware of some of these symptoms and get evaluated would be a great deal for our patients.
You mentioned that there might be even more people with atrial fibrillation in the future. Say that fast 5 times. Um, Chris, what causes people to develop atrial fibrillation?
So there's a whole bunch of comorbidities that could cause this. Mainly things that are really in parallel with developing atrial fibrillation is when someone has long-standing high blood pressure or hypertension. Also, if someone has sleep apnea, that's another trigger towards this. Sometimes things are in combination of alcohol use and caffeine, or if their thyroid hormones are off balance, those are all triggers. But it seems to be that our best predictor is the longer we age or the more we age, that's when atrial fibrillation starts to come. And that's probably because of longstanding or unnoticed or untreated hypertension, but also because you have stretch and scar and fibrosis in the top chamber of the heart, which makes it much easier for atrial fibrillation to happen.
So, how do you diagnose this and make certain it isn't some other arrhythmia or something else?
Very important, right? Because if we diagnose it, we are able to say you have this and what are the next steps in your treatment care plan to do this. The best way to diagnose this, some people are really good and say, well, you're irregular on physical exam when we're listening to your heart or looking at your neck veins and cardiac pulsations. Some people could pick it up now with the Apple Watches or iPads and iPods, all of these things. But really the gold standard is to document this rhythm on an EKG.
Okay. And then how do you treat it once you know it's there?
Well, that's a great question. And treatment all depends on what the patient's feeling. Some patients are what we call asymptomatic and they're not aware they're in atrial fibrillation whatsoever. If that's the case, the best treatment for those patients are to make sure their heart rate doesn't go over 100 beats per minute in a 24-hour period, that their heart's not weakened from being in atrial fibrillation, and based on a risk score that we use, criteria, whether or not they need to be on blood thinning medication to prevent stroke, because stroke is the worst part of atrial fibrillation, fivefold at least risk of
Mm.
stroke if patients are in atrial fibrillation.
Why
So
is
those are
that,
the key.
Chris?
It's more so of what we call it's kind of like the appendix of the heart. It's called the left atrial appendage, and it's felt that 90 to 95% of the clots form there. What happens is you have blood stasis and pooling, and it's kind of this reservoir in the heart that kind of just fills up and it kind of curdles itself like cheese, milk and cheese, and it kind of just stays there. And because that's on the left side of the heart, that could embolize to the brain and cause patients a stroke, unfortunately.
Hmm. What does it mean when someone has an ablation procedure for atrial fibrillation?
Excellent. So our strategies would be uh, rate controlling medicine, so we keep the heart rate low or within a reasonable range to protect the heart from getting weaker. Other options, what we term rhythm controlling approaches. And that means let's keep you out of atrial fibrillation because you feel better and or the pumping function in your heart's better when you're in normal sinus rhythm. And that's what we call normal rhythm, sinus rhythm. It's the rhythm that God gave us. Here's our electricity pacemaker in the heart that God gave us when we were all born, and let's stay in that. And an ablation procedure is one attempt at rhythm when
Hmm.
either an antiarrhythmic drug fails, or a patient cannot tolerate or doesn't prefer to be on an antiarrhythmic agent. And what we do for the ablations is we know where the triggers and where the atrial fibrillation sort of monsters lie. And these are at the
Mhm.
top chamber, the top of the house on the left side. And these are called pulmonary vein triggers. So when we're all born, we grow out our lung buds from the heart. And some of those lung veins, which are going to, again, in adult life and in all types of life, will bring oxygenated blood from the lungs and drop it into the left atrium, the top chamber of the heart. Some of the left atrial tissue is pulled into the veins itself, and those are the triggers. So, for example, another analogy, those are like matchsticks, I tell my patients. They get very angry, and then you start throwing little matchsticks on fire into the heart. And the heart's like a stack of logs, and one of those matches are going to catch and set the heart on fire, and that's what starts off atrial fibrillation. So an approach is catheter-based ablation, where I'm sure our listeners may have heard or know somebody that have had coronary angiograms, where they go up through the groin arteries to look at the blood flow in the heart. This, we go up through the veins in the groins. We go up into the heart with several catheters. We use a pretty cool, it's almost like a video game. We use a 3D mapping system to try to figure out where the heart is in space and time and measure that up with where our catheters are, which could also tell us where we are in space and time. What we do is inside of the heart, but outside of the pulmonary veins, we try to form ablation lesions to kind of cage the tiger or cage these matchsticks from firing away. And that's a first and initial approach to patients to try to say, let's do what we can to reduce the likelihood you'll go into atrial fibrillation. Let's make it really hard for you to go back into atrial fibrillation.
Mm,
It's not a cure, but as I tell my patients, think about it as taking a one-time really great drug.
hmm. Well, speaking of drugs, when people are controlled or treat their atrial fibrillation with medications, are they usually on them for life?
It's a good question. So any ablation we do, because we cannot cure atrial fibrillation for anything, drugs or ablation, still doesn't affect their stroke risk. So
Oh,
patients will still be on blood thinners lifelong if they necessitate based on their risk criteria. So ablation, drugs, anything, no matter if there's sinus rhythm or not, they still will be on blood thinners lifelong. Now, in terms of whether they need to be on the other agents, that's
mhm.
all depending on how well the ablation takes, how well their body, as well as the risk factor modifications, such as exercise, weight loss, controlling their sleep apnea and blood pressure takes place. But it's very common for us to get patients off of all of those, quote, antiarrhythmic medications after ablation procedures. Sometimes patients have more advanced forms of atrial fibrillation and they need both catheter ablation plus a drug.
Hmm. Chris, I want to go back to something you just said, where you said it depended somewhat on if they modified their risk factors, exercised, managed their sleep apnea, et cetera, et cetera. So can you r- reverse your atrial fibrillation, or does reducing your risk stop you from having it?
It's so that's a fantastic point. So there's been large studies as that show such a benefit if patients do weight loss and risk factor modification. It's almost on the same parallel as our best drug in cardiology. It's really, really good. And reversing it would kind of be taking it to where you don't have much atrial fibrillation. And also reversing it means you could change the substrate of your heart, meaning the top chamber of the heart kind of says, oh, I like being in atrial fibrillation. And I'm scarring up. I'm seeing all these pressures. I'm changing. I'm becoming more stiffer. But if you could keep patients in sinus rhythm and they stay in it, you could cause what we call left atrial remodeling. So remodeling of that chamber of the heart. And patients do very, very well with that approach. So I would say that all three of these risk factor modifications, catheter ablation, plus or minus drugs, as well as blood thinners are mainstays in our treatment for atrial fibrillation.
Well, Chris, I'm an anesthesiologist and I learned something new today. Anything else that you want to share with our listeners today?
I just really appreciate this opportunity because atrial fibrillation's out there. More of it's unfortunately likely going to come. And I think our patients have lots and lots of questions. And to see this in their chart or to be told about it, I hope our video makes them more informed, less scared, and likely to come see us and visit with us and have this discussion because we could really improve their quality of life, reduce their risk of stroke, intervene early, and have a good impact on their quality of life.
I do think it is amazing what a difference it can make to have heard those words before, atrial fibrillation, before you just encounter it somewhere.
I think so. And patients really do feel tremendous improvement in their quality of life when we keep them in normal rhythm. So I think this is fantastic. And I thank you very much.
Well, thanks for being here, Chris. Our thanks to Mayo Clinic cardiologist and cardiac electrophysiologist, Dr. Chris DeSimone, for being here with us today to talk about this important topic of atrial fibrillation. I hope that you learned something. I know that I did. We wish each of you a very wonderful day.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.